Okay.
I'd like to welcome everybody to today's webinar, in which we will provide an overview of the final MACRA rule. Now, I'm going to forewarn you, there is a ton of detail. It was really tough to decide what goes in the overview and what's going to go in 3 follow-up webinars that we've got, one covering the information blocking and ONC ACB audits. We're going to do a MIPS deep dive. We're going to do an APM deep dive. So look for that schedule. It's actually was on the loop that we were running previously, and we will also be sending out the slides, which you can find the schedule of webinars on the last slide. Also, if you just look on our webpage or our Facebook page, you can see them there as well.
Yeah, and the information blocking, we're only doing one webinar for that, and it's this Thursday. The MIPS deep dive and the APM deep dive, we're going to do 2 each of those, but I just wanted to kind of give you a heads up. And the information blocking has both an IT and a legal background, so you may want to make sure that you have the appropriate people from your organization involved.
So today we are going to talk about, again from a high level, the MACRA regulation, some of the procedures. We're going to put a smidge of 2016 reporting in here as well because of a recent rule change there. But now the MACRA regulation does refer heavily to the Stage 2 and Stage 3 final rule, which you can find out. We've got a recording of that webinar posted to the CliniSync YouTube channel, and if you go to the link that's on this page, you can go directly to the 2015-2017 final rule. And we kind of like this slide because it's Cathy and Ms. Costello and I and Ms. Cathy Rich. We're here to help you guys. Sometimes we kind of feel like a dog being launched into space, and we just hope that flight crew brings us back down. And like I believe it was the Russians that sent a doggy on a one-way trip. Yeah. Okay. Now, in addition to that huge MACRA regulation, which was 2,300 pages, we've also seen a flurry of activity around the changes to 2016 meaningful use for everyone and 2017 for the hospitals, which you found in the hospital outpatient rule. Then the hospital inpatient rule, they had some tweaks to the CQMs and reporting a little bit of meaningful use. ONC health IT certification rule, of course MACRA, and the physician fee schedule rule, and there was 1 or 2 other little rules that dropped in there. Probably 8,000 pages of wonderful reading. My recommendation, take things in small bites. Focus on areas where these programs overlap and kind of first look to see where you can exclude folks or systems or people, and then go from there. Just chop it into smaller bites as you go along. But we're going to have a few little details about each of these rules, but again, primary focus being MACRA. So let's take a look real quick at 2016. For your provider side, your eligible provider, 2016 is a 90-day reporting period. It is a rolling 90 days. Your meaningful use reporting period can differ from your reporting period for your CQMs. They can be exactly the same. They can be different. Doesn't matter. If you are reporting eCQMs, then you're going to report for a full year through the PQRS program. My recommendation has been and always will be, when you're doing your meaningful use attestation, go ahead and attest to your CQMs, even if you're doing a full year eCQM to PQRS, because we've seen some craziness there. You're going to have 9 measures. You got the 2 public health requirements and 9 CQMs. Now, the attestation's not going to open until January 1st. Even though that hospital rule, the hospital outpatient rule dropped that had the meaningful use changes in it, the effective date is not until January 1. On the hospital side, same thing. You got a 90-day reporting period. You have 8 measures. You do have the 3 public health or registry reporting measures. Now, hospitals do have the requirement to do 4 eCQMs. That's either 3rd or 4th quarter data. You submit that through the QualityNet portal. By doing so, you have met the CQM requirement. For the CAHs, it's attestation has always been for the CQMs. And again, for those CAHs that are attesting to their CQMs, your 90-day period for CQMs can differ. So with that, I'm going to turn it over to my partner in crime, Miss Cathy Costello.
Hey everyone, thanks for joining us. We want to start out by making sure that you understand what are some very significant differences between what we've traditionally have called the Meaningful Use Program and what we will now, at least on the physician EP side, be calling the MIPS program. Meaningful use, as we started back in 2011, was either Medicare or Medicaid. The hospitals could do both. The physicians and other ambulatory providers could only do one or the other. Medicare included MDs, DOs, dentists, chiropractors, optometrists, and podiatrists. The Medicaid program included nurse practitioners, PAs, nurse midwives, and CRNAs. Medicare, as I think everyone knows by now, the Medicare Meaningful Use Program ends at the end of this year. So you will attest for 2016, but you will no longer do Medicare Meaningful Use. You will instead move into the MIPS program. Medicaid incentives for EHR reporting will continue until 2021, assuming that you have registered and participated at least once in 2016. Then you will be eligible for incentives all the way out till 2021, and that program will run side by side with the MIPS program, and we'll talk about how they blend together. The MIPS program only covers, at this point, Medicare fee-for-service providers, Medicare Part B fee-for-service providers. That may expand over the next few years, but for your thinking for 2017, this is where you begin. It is very important, though, that you understand, whereas when we started Meaningful Use, the two programs were mutually exclusive for the ambulatory providers for Medicare and Medicaid. Now you need to think about MIPS as a payment program and not as an EHR incentive program, because even though you may have providers who are continuing on in the Medicaid track for EHR incentives, you may well still have to be reporting them under the MIPS program if they're identified in your claims for Medicare Part B services, if their NPI appears on the claims. So think about that. You're going to be doing double reporting for some of these people, including your nurse practitioners and your PAs. That's something we'll talk about a little bit more. Another change, and we'll spend a lot of time on this in the deep dive, is there will not be the traditional thresholds that you're thinking for your ambulatory providers under MIPS. You will continue to have that under Medicaid. We'll talk about what the various measures are. You do get a bonus under the MIPS program for public health reporting, and you can report as a group and aggregate measures, whereas Medicaid will continue to be individual provider by provider reporting. Okay, to kind of pull together the various timelines that you have and the various methods of reporting, especially if you're in a hospital system. You basically are going to have three different buckets you're going to work with not necessarily the same identical reporting options. So let's look at that up front. Your Medicare, what are now being called eligible clinicians, ECs. ECs are like we called EPs in the Medicare incentive program. In the EHR incentive program, is now being called ECs and are expanded to cover your nurse practitioners and your PAs and nurse midwives. So the ECs are all under the MIPS program, as I said, if they bill for Medicare Part B fee-for-service in their claims and they're identified by NPI. In 2017, all reporting, including Medicare, Medicaid, and hospital-based reporting, will be 90 days. 90 days, very important. A lot of people waited to see how 2017 is going to be handled, so you have some idea of your move to stage 3 and how to integrate it and everything else. So 90 days for everyone. They've made that clear in, that came out in the last of the regs to drop, which was just a few days ago. The hospital outpatient rule it expressly states this. For the Medicare ECs, you'll have MIPS transition measures, which are stage 2, or you can move into stage 3. And there, as we do the deep dive next week, you'll see where how you report that changes. Okay, make sure that you include your Medicaid providers in your Medicare reporting for ECs. Now, your Medicaid EPs is the more traditional look at how we think about meaningful use and the incentive programs as we've worked with to date. They also will have 90 days. Their measures will look a lot like what you're doing this year, where you're looking at a modified stage 2 or possibly a stage 3. And you would be using, if you're using stage 2, you're going to be using 2014 edition cert. If you're doing stage 3, you'll be using either a combination of 2014, 2015, or a straight 2015 edition cert. For the hospitals, again, 90 days. And hospitals, this includes those of you who are Medicare and Medicaid eligible. Even if you're continuing to draw down your Medicaid incentives, you would attest with the Medicare measures, and that would flow through to the hospital. I know MPIP is planning to have a lot of information on Medicaid reporting, but the hospital rule clearly states that hospitals who are dual eligibles will be reporting under the Medicare measures. The Medicare measures for both modified stage 2 and stage 3 will, for the hospitals, will not include CPOE and CDS. So clinical decision support and CPOE is being removed for the hospitals in 2017. And we'll talk about in the MIPS deep dive next week how that also affects the eligible clinicians. In addition, the measures changed, and there are only going to be 3 public health reporting measures or specialty registry measures for the hospitals for stage 3, which is a rollback from the 4 they had required in the regs last year. Okay, in more than one of the regulations that have come down in the past few weeks, CMS reiterates several times that the Medicaid program and the Medicare program are no longer going to be in tandem, and they specifically say the requirements for the Medicaid EHR incentive program for EPs were not impacted by MACRA. And they go on to state in the hospital rule, while the MIPS objectives for the advancing care information, which is what we traditionally have called meaningful use category, are aligned to some extent with stage 3 for the Medicaid program, they are 2 distinct programs and reporting will stay separate. So those of you who handle your meaningful use reporting for an organization and you've dealt with both Medicare and Medicaid, you are going to have to set yourself up with 3 separate tracks because the reporting will not be the same, and you will confuse yourself if you don't put all your providers, a list together of all the providers and where you're testing. Medicare, Medicaid, both Medicare and Medicaid, and hospital-based. Okay, here are the areas of difference between the MIPS payment program, as I said, payment program as opposed to EHR incentive program, and the Medicaid EHR incentive program. We already looked at eligibility. Important to note, and we will talk about this in a few slides, the opportunity to attest as a group is very, very important change, I think, in the MIPS regulations.
Absolutely.
As I said, there are no benchmarks. We're going to look at that in depth because there's kind of a tricky weighting of the categories and what you are and are not required to report. But I do want to say, and as I said, the Medicaid looks very traditional compared to what you've been reporting. If you do not move to stage 3 in 2017, you will be looking at virtually the same attestations that you have in 2016. But as I said, Medicaid MPIP will be providing a lot more information on this. But I do want to point out, if you're dealing with hospital-based physicians, there's a significant difference between the two programs. Traditionally, when we were dealing with meaningful use, the definition of a hospital-based physician was an individual who performed 90% or greater of all their services at a place of service POS 21 or 23, which is the hospital, inpatient, or the ED, were then totally excluded from the meaningful use reporting. Now we know that there were really problems with Medicare making, or CMS making the information available to you in advance about whether in a given year a physician fell into this category, but we'll talk about their attempt with the MIPS program to provide that information up front. But in the MIPS program, the definition of hospital-based physician totally changes, so please pay attention to this. First of all, it expands the place of service that is considered hospital-based to include POS 22, which is the hospital outpatient providers. And it drops the percent of their claims that have to be considered hospital-based from 90% to 75% of the services are POS 21, 22, or 23. So inpatient, hospital outpatient, or hospital ED. These individuals, the hospital-based physicians, can attest to what we call traditionally meaningful use, but do not have to. They can be excluded as a group for that part of the reporting.
Yeah, so let's go into that in a little more details. Cathy shared the threshold to be included as a hospital-based provider is 75%. They did add POS 22. Now the determination period, the period of time that CMS is going to look at is a year starting September 1st of 2015, ending on August 31st of 2016. So they're going to look at that period of time, work up the math. If they're above 75% for POS 21, 22, 23, they are then deemed to be hospital-based providers. Those hospital-based providers must attest to MIPS unless, of course, they're a low volume, they're a brand new provider, or they're in an APM. Now, the biggest impact is going to be around the ACI, which is what was meaningful use. If you are unable as a hospital-based provider to attest to meaningful use or ACI, then they are going to reweight that category to 0. So under this new classification, you're probably going to have some providers that are using your ambulatory EHR, and hey, if you can attest to ACI, do it, because it makes the math easier if they're following the same calculation as your other providers. But if they're, traditional hospitalist, ED, your EHR kind of scores, it kind of, it puts all those measures together. But talk to your EHR vendor, because we don't know what this is going to mean in future years. That exclusion for the ACI could go away. So for those of you that have, your Meditech, your Epics that are doing true hospital-based MU reporting, talk to your vendor and say, hey, if Dr. Bob needs to attest, how can we do that?
Yeah, but the nice thing about this, and I know many of you have really ripped your hair out in the EHR incentive program for meaningful use, that in the hospital-based providers, there were a whole bunch of measures that you took exclusions on because they weren't doing that type of work.
Yep.
They, you know, providing patient ed and access to information, stuff that they had no control over. And so this gives you the option. Hospital-based, you can either don't have to report at all, and you take a 0 in that category, and we'll show you how the impact of that is, or you report and you can include them as part of the group. You don't have to strip them out and worry about whether you're reporting for them or not.
And as we do progress through this presentation, please pay attention to where getting a 0 in a category is much different than the category being reweighted to 0. And it gets kind of crazy with the math. But the other category of provider that we've had problems with in the past has been those non-patient facing providers. Well, guess what? They're included in MIPS. They've always been excluded from meaningful use. The way they determine if you're a non-patient facing is if an individual bills less than 100 patient facing encounters, or if you're in a group that 75% of the providers are deemed non-patient facing, then you will be classified as non-patient facing. Now, unlike with hospital providers where they look at one period of time, for the non-patient facing, they're going to look at 2 different periods of time. They're going to look at September 1st, 2015 to end of August 2016, and then they're going to look again from the middle of August, or I'm sorry, from September 2016 to the end of August 2017. If at either time the provider is deemed to be non-patient facing, then then things are going to be reweighted around, because it's quality is hard to report, meaningful use is hard to report for those non-patient facing providers. So we don't know what that reweighting is going to look like.
Yeah, and when we say non-patient facing, what you're considering are the ones that traditionally were excluded from meaningful use because they had a blanket exemption for
pathology, radiology,
anesthesiology. So this is really what they're thinking of when they think non-patient facing. I'm sure you can come up with some other subspecialties, but basically this is how you're going to be handling these groups. They are now in MIPS, but not necessarily within the meaningful use type of reporting.
They're dipping their toe in MIPS.
Yes, right, right, because MIPS is a payment program, and what you have to be careful of is make sure that they're included in your reporting for other categories, because you don't want to accidentally incur penalties for them in an area where they previously weren't subject to penalties.
Now, for FQHCs and RHCs, you're kind of sitting on the sidelines for this, good or bad, but there is one exception. Due to the billing methodology, things don't fit in the MIPS program. But for those services or procedures that you bill outside of your FQHC billing, or if you're in a CAH, RHC that you bill method 2, those are included in MIPS. So you could in an FQHC or an RHC have a provider who exceeds the minimum threshold and then would be subject to MIPS. So keep a close eye on that. Also, locum tenens, they're really sitting on the outside of MIPS, kind of, because when a true locum tenens is they are working and billing in place of that provider. So it is important that locum tenens pay attention to their quality, because if you have a locum tenens that's replacing Dr. Bob while he's out, he is working as Dr. Bob. Now also think about your temporary providers. Depending on how long that temp is there, you could have some challenges or some additional things to think about with respect to MIPS. Back to Cathy.
Okay, is this how you feel? This is how we felt. When we started looking at those regs, I have to tell you, I'm sorry, my threshold is 3,000 pages.
Gosh.
Forget it, everything beyond that. But anyway, as you can see, CMS just gave us so many new acronyms. I'm sure it's just what you'd love to see. But the most important acronym when you're trying to understand what MIPS is all about is this Composite Performance Score, CPS, Composite Performance Score, because basically this is going to drive all your payment in your ambulatory providers. All the payment is driven by basically how did you do on that test anyway? How did you do on that ACT or SAT or anything else? Composite Performance Score. It is going to be regraded every year, and this information will be made publicly available on the Physician Compare website. So you really want to pay attention to this. Don't just kind of blow it off and say, oh, we can get by with reporting, because you can't. I mean, you can avoid penalties and maybe arrive at a 0% as far as incentives or something. But the reality is this is all going to start to be made publicly available, and we know how messy that can get if somebody decides to just run through and give a high-level view of, you know, your doctors versus the doctors 5 miles down the street type of thing. So let's look at how this works, and as I said, we're going to have to defer until our deep dive on the MIPS, a lot of the details, but I want you to get the overview because it's really important to understand how this all works, and then we'll go into the details. So every year is like a new year in MIPS. It's a new year for the physicians, for their reporting, for who may be eligible to report, because CMS is looking at increasing the number of providers every year that have to report under MIPS, so you have to watch for that. And the other thing that changes is how much weight each category is given. There are 4 basic categories in the MIPS program. One is, as we said, we used to call meaningful use, which is now called advancing care information. Is being reported totally differently, but you'll be familiar with the underlying categories. The quality reporting used to be called PQRS and is still called PQRS in 2016. Resource use is the cost metrics that, if you've been looking at your QRUR, your quality cost reports, is that cost factor, and that is calculated every year based on claims. And then the last one is this brand new area called clinical practice improvement. So
now with clinical practice improvement, it has a sprinkling of the old meaningful use measures with some of it, yeah. But also you'll see a lot of the items that are in there are probably something that your quality and process improvement team, if you're in a health system, it's something that your QAPI team is probably already doing, and something that you can make a minor tweak to and get your credit for that category.
Yeah, and every single provider, I don't care if they're the smallest physician provider practice versus a huge system, is going to have numerous areas of clinical practice improvement that fit the bill for what you do. A lot of the time it's done in relation to specialty certification and stuff. Sometimes it's done just, you know, how you set up your practice. Are you doing connections to the HIE? Are you doing chronic care management? So there's a lot of places. It's really going to become just becoming familiar with it. And when we do the deep dive next week, we'll show you how to split that up and understand that a little bit better. But in 2017, the good news is nobody who is graded under MIPS is going to be given any type of weight is given to the cost factor. So if you're costing, your patients are costing CMS more than the national average, or you have more admissions, readmissions, it does not impact what is the ultimate score for your providers. There's only going to be 3 areas that providers are scored on for MIPS in 2017. One of those is the meaningful use advancing care information is 25%. Quality reporting, big, this is where you want to spend your time. 60% of your score, or your provider score, goes to quality reporting. The new area, the clinical practice improvement, is only being weighted at 15%. But let me say, if you have physicians in one of those specialty categories, if they're the hospital-based or they're the non-patient facing, and you have to remove the meaningful use because they don't report in that area, then the 2 remaining categories, quality and clinical practice improvement, will be upped in their percentages for 2017 for those providers.
Spend time on those quality measures.
Quality.
Train
is
those
at
workflows.
the very least 60% of all your physicians grading and maybe more. Okay, the options in 2017, and I know this has gotten a lot of play in the healthcare press in the past 6 months, and you know, CMS has been like, oh, we're going to make it's go at your own speed, you know, do what you want to do type of thing, and we're just interested in getting people familiar with MIPS. And to a certain extent that's true, but let's pay a little bit of attention to what goes into each of those 4 categories, because I would like to see as many providers as possible get beyond that avoiding penalty option. Absolutely. Option 1 is just avoiding penalties. What do you need to do so that you don't get a -2% or -4%? Because it's supposed to be 4% starting in 2017. You only need to report 1 clinical quality measure, 1 clinical practice improvement activity, or 1 patient for each of the 4 basic categories for meaningful use, and we'll talk about that again next week. But basically, very, very, very minimal lift here. If you do 1 in any one of those categories, that provider will avoid penalties in 2017. But with that being said, let's look at the other options, because I think for anybody who's listening in on this, you already have a good working knowledge of what we've done to this point in time, and there's no reason that you can't move to option 2 or option 3 and consider getting some type of incentive.
Because think of it in terms of meaningful use. You have less measures. Think of it in terms of PQRS. You have less quality measures you have to report. You know, so yeah, there's some other funkiness out there, but those 2 programs in and of themselves, you have less to do.
Yeah, and if you have a Medicaid provider and you're still drawing down EHR incentives, meaningful use incentives, you could be getting incentives for them for meaningful use and also getting incentives for MIPS. So it's really worth looking at. So option 2 is what I call the we'll give you credit for good effort. I mean, CMS is just basically saying if you report above the minimum in option 1, but you don't make it quite to the full package, they're still going to give you credit. Unlike with meaningful use, if you were reporting meaningful use and you missed 1 measure, you know that you lost your incentive payment for that year. So what CMS is doing here is to create the good effort category, and that is you report on more than 1 quality measure, more than 1 CPIA, or you report more than just the base measures, but you may not have everything that you would need to be considered a full reporting for MIPS. You will still get credit for it.
And I wouldn't bank on that potential small incentive.
Yeah, I'm saying, who knows? You know, maybe 1%. But I think what CMS is trying to do is to encourage people to get into the program, and then they'll worry about refining the message so people understand what they really need to be doing. So let's look at the next 2, which I think is really where the meat and potatoes are here, because there's very little to me that says that you can't be meeting that option 3 or option 4 if you're part of an advanced payment model. But option 3 is really where the reporting is in 2017 for Medicare. You either can do a 90-day or greater all the way up to 1-year reporting, which will avoid penalties and receive increased incentives. And what is included in this part of the reporting are 6 quality measures. There may be less if it's a subspecialty. We'll talk about that next week. But basically, why don't you assume that you're going to have to be doing 6 quality measures, clinical practice improvement activities that equal 40 points, or if you're PCMH certified, you don't have to do anything else. We'll talk about that next week. And you do all 4 base measures for advancing clinical care information.
And remember, it's all base. Your base, you have to get one patient in each of those measures.
Yeah, and so if you do 90 days, you have met your requirements. You should be getting at least a minimum incentive payment. But honestly, I've looked at both the Quality Payment Program, QPP website, and all their handouts and the regs and everything else. And to me, it is not clear that you would be eligible for the full 4% that they list for MIPS for 2017 by doing less than a year's reporting. You definitely can get an incentive, but I'm just heads up, if you can get your providers to do 90 days, there should be very little reason that you can't do 1 year. It's not like you're going to test early for it. So think about that, because if you're trying to draw down the whole 4%, 2017 is going to be the easiest year to do this in because they've cut back a lot of the thresholds. But I would consider including a full year's worth of your meaningful use reporting, full year of your quality metrics, and we'll talk about the CPIA next week. But that's where I'd like to see you set your sights, just because I'd like to see as many providers as possible get the 4%. The last category is if you have providers who are part of what we call an advanced alternative payment model. And we'll look at those definitions in a few slides, because not everyone who's in an APM, like shared savings programs, are not going to fall into this category this year for 2017. But for those that do, you don't have to do any additional reporting, because all the reporting is covered by the advanced APM, and those providers will automatically receive a 5% pay increase on their Medicare Part B claims in 2019 for their 2017 reporting period. But I have to stress again, we will look at this in a few slides. Not everyone who's in an alternative payment model right now will fall into this advanced category that automatically earns the 5%, where you don't have to worry about other reporting.
And CMS is publishing a list of those that are considered.
Yeah. And we will. That's the important thing. A lot of this information is supposed to be available to you in advance, so you don't have to scramble like we did for meaningful use for years to figure out who's in and who's not. But we'll talk about that process in a little bit. Okay, the most significant change to me in the MIPS program, and I have to say, for those of you who have suffered for years and years and years trying to test for even a few providers all the way up to several hundred, the concept of group reporting is like such a bonus.
Absolutely.
Because it covers such a multitude of sins. I mean, you can have, and when I say group, and what CMS means by group is all the providers under one tax ID. And there's going to be different ways you report if it's a tax ID that's an alternative payment model versus a non-alternative payment model, but the principle is the same. All the actions of the providers under that group cover reporting for everyone in that group, and you don't have to worry about making sure every single provider's met a certain measure or anything. And
that's really going to help for those providers you have that are deemed hospital-based or non-patient facing. Like Cathy said, it covers up those sins, or it covers that up by everyone who could report for all of the measures and whatnot. So.
And then the other nice thing about the group reporting, those of you who have done GPRO, which is group reporting for quality metrics the past few years, will know what I'm talking about. And that is, it was a real pain to make sure that everyone got their GPRO registrations in on time to be able to report as a group. And it was always halfway through the year. I mean, you had to know by June 30th what your whole process was by the end of the year. And so it's crazy. A lot of people missed that GPRO sign up, and then they had to report their providers individually. And the group filing for MIPS does not require advanced identification as a group with just a very basic two basic exceptions. One is if you're in a part of an advanced payment model, obviously under contracting with CMS, that is considered a group. And the second one is if you're using the Medicare portal for CMS portal for reporting, that requires identification as a group because they assign you your patients. But other than that, you know, for quality reporting, for meaningful use, for anything else, you do not. And the resource use for the group, which is the cost factors, it looks very much like your QR/UR report for that TIN. It will basically aggregate all the claims and report on it as a group. The one thing I have to specify, though, when you're looking at group reporting, and this is important to keep in mind, we'll talk about it again next week, but you have to basically continue on as a group through all the areas of reporting, through your meaningful use ACI reporting, through your quality reporting, for your advancing care information. Once you commit to report as a group, you report all three categories as a group, and it's just how you transmit your information. You're welcome to change from one category to the next, but you have to maintain group reporting.
Now also, even though you will not be weighted on your cost, you will get that cost figure on your report,
right.
which we think is going to look just like your QR. For the most part.
So you know, honestly, those are helpful if you can take the months it takes to figure out what you're looking at. They're actually quite helpful if you're trying to get into a program in which improvement is one of the goals, which we will talk about on the MIPS. But although it does not come into play in 2017, over time, the improvement of a practice's or a provider's scores is taken into account in their reimbursement. The various methods that you can use for group submission are, and we have another slide about this, are basically your specialized registries, what used to be called PQRS registries, your EHR vendors, or CMS web interfaces. You will always have, if you are part of a group that does CAHPS survey reporting, which is the patient satisfaction surveys, those will always need to be registered in advance because, again, it's an outside vendor that does that. Okay, back to Scott.
This graphic kind of makes me laugh a little bit because with the galaxy there, kind of made me think about string theory. And if you can understand string theory, you can understand MACRA. So.
And if you think he understands string theory,
I have no idea.
Believe me, we have land in Florida. We can tell you.
Yeah, you can buy it with wooden nickels. But really, when you start to look, first, again, as I shared earlier, break it down into smaller bites. Try to understand how your eligibility is determined. Look for your exclusions. Think about that Medicaid incentive program because you want to cash out there as well. You want to get those dollars. And then, of course, you got to be looking at if you're a member of an ACO or some other bundled payments, CPC Plus. You've got to think about all of that when you're trying to determine your eligibility. So first, we recommend look at your exclusions. If they don't need to be in the bucket, get them out of the bucket. Are they excluded on low volume? Are they a provider that's new to billing? You know, are they fresh out of school? They've never dropped a bill before. They're excluded from the program. Then if you have some providers that are in an ACO or in some, they're a QP or a partial QP, that just means if they're an alternative payment model, they're out as well. And then now that you have your list, categorize those providers. Are they hospital, non-patient facing? Are they in your shared savings program? Are they in some, I don't know, the ESRD program, any of these other payment models? And then again, think about the impact on reporting. And then how are you going to report? And this how you're going to report is going to look different from last year. Now, if PQRS, you're used to submitting PQRS through a registry, a QCDR, through your vendor, those are still going to be options for you, but you have this new data that's going to be submitted, that meaningful use data, the ACI, and your practice improvement. I'm going to be honest, nobody really knows what that's going to look like yet. Those are going to be put in place over the coming year. There's going to be a lot of information coming out, and we're going to do our best to keep you guys in the loop on that. So now you need to, again, once you've determined, in the determination if you've got to report, again, really concentrate on your exclusions. It's MDs, DOs, MPs, PAs, chiros, that whole list. If you're any other type of provider, you are not going to report in 2017. But for those of you that are running this program, I want you to look forward, because at some point your PTs, your OTs,
the psychologists, which is one we're asked about a lot, and the social workers are another category that down the road are going to have to report. But for 2017, just take it to the bank. This is the list of providers that you need to test for.
So think about the impact in future years and start nudging your organization in that direction. Then low volume, again, CMS is going to provide this information prior to the start of the reporting period. And guess what? You got 23 days, CMS, so I hope we're going to get this information soon. Also that non-patient facing, there's 2 determination periods there. And again, if you're new to Medicare, you're a new provider, and then the QP. So just think about your different exclusion types. If you can get them out of the bucket, get them out of the bucket.
Yeah, let's talk about low volume for a second, because I think this is, again, probably the second most significant thing that MIPS did, because we always were being asked, what about a provider who only has, 10 patients in a year? They're a teaching provider or something. Under the new MIPS system, this low volume is handled completely differently. And you've got 2 categories that can make you a low volume provider. One is that you bill for less than 100 unique patients under Medicare Part B in a year, or that you bill less than $30,000 in Medicare Part B claims.
And that's either or both?
It's either or. The proposed rules had it both, but they changed that because of the comments. We had pediatric subspecialists who only had a handful of patients, but they were very high-cost patients because they take care of them all the way through their adult care. And so they were concerned about that. The other place where you see this very significant is in small hospitals that may have less than 100 Medicare Part B billing under their hospital tax ID, not their physician tax ID, but their hospital tax ID. Those patients were being transported, very high cost because they were being transported, but those costs were being pushed back to the hospital's tax ID. So it's very important that these be excluded, and CMS has decided to look at the low patient volume exclusion twice, as Scott said, and if in either of those reporting periods the low patient volume threshold is met, then those practitioners are automatically excluded from MIPS. They cannot, even if you report for them voluntarily, they will not be subject to either incentives or penalties. So just a different way of thinking about it.
Yeah, and also if you're reporting as a group and you have a low volume in there,
keep it in. You don't want to, if you're reporting for 50 providers, you don't want to have to go through and start pulling meaningful use measures out for who's reporting and who's not. You can leave it in, and CMS just won't give you any penalties or incentives for that provider, but they can be included in your calculations. Okay, now the various options for reporting, and again, this will be really important to hear in the MIPS deep dive, but you can continue to do your quality reporting through claims if it's a small provider who attaches G codes and stuff. You can do that. The CMS is, over time, is going to phase that out.
And we don't know what that means for those providers. You're going to be doing your quality through claims, but your practice improvement and your ACI is probably going to be some form of attestation on top of that.
Right. And let's face it, these regs have dozens of pages on registry reporting. It's become the new hottest form of submission of data to CMS in all 3 of the categories where you'll have to be reporting. So we'll talk about that next week, but just kind of a heads up. CMS has really painted registry reporting, whether it's the specialty registries or the PQRS registries, have taken on a larger role under MIPS. And some of that is I don't think they can manage as much data as they thought they were originally a few years ago. It's just an enormous amount of data and data processing. You can continue, as I said, to submit through your EHR vendor, whom I'm sure many of the vendors will offer reporting for the meaningful use component also, because it's very minimal reporting, or the clinical practice improvement, which is going to be a yes/no. So just be aware that there's different ways you can meet this. After you hear everything over the next few weeks, just be thinking about and exploring what you want to do. You don't have to make a decision until sometime next year, but just be aware you have many options here on reporting. Okay, APM reporting. We're just going to take a minute on this. We're going to have a whole hour's worth on this. I think the week after next, maybe it's next week.
Yeah.
Next week, I guess. Okay, so the things that define a MIPS APM, so there's many APM models. Some of you will have alternative payment models already with your commercial payers. Some of them have contracted with people for that. But whether or not it falls into a MIPS APM, is it recognized by CMS? Because you may have plenty of other alternative payment models, but unless you have an agreement that goes to CMS, and is with CMS, it is not going to be a MIPS APM. You must have a MIPS eligible clinician as part of it, and you must pay payments related to the quality of the performance by your eligible clinicians. In addition, this sounds, in this day and age, we were really surprised this was built in until we started looking at some of the stuff. Advanced APMs have to require their participants to use electronic health records. And I thought this was kind of a throwaway until we realized, for example, in the Medicaid CPC that's just going to be kicking off in 2017 in Ohio, there is no requirement for EHR reporting. So in that case, at least for 2017, the Ohio Medicaid CPC will not be considered an advanced APM.
CPC Plus will.
CPC Plus on the Medicare side will be. And as you said, linked to quality, and there is a requirement of risk bearing. We'll go into that when we do the deep dive. Again, CMS is trying to provide for you information up front as to which providers are part of an advanced APM and which aren't. And so not only will it be that list that you send them when you contract with CMS to be an APM, whether it's a shared savings or whatever, but CMS will look 3 more times during the year to see who the providers are on your list. March 31st, June 30th, and August 31st. So at any time in those 4 categories, a provider's name appears on your APM list, they will be counted with that APM, whether it's an advanced APM or not. And the oncology care model is decided a little bit different timeline, but you know, that's very specialized. Okay, now let's, and more, as I said, we will be going through this again and again over the next couple weeks on these webinars. So this is kind of a high-level view, but we want you to understand the process. So I'm going to have Scott kind of run you through hardship exceptions, which is the end of the process for most of us.
Right, and for the hardship exceptions, think about kind of the programs that we have in place right now. Under meaningful use, you would file a hardship if you have some technical issue with your EHR and whatnot, and that also still applies under the ACI category. We're not clear what the process is going to look like. I'm sure we'll know that sometime next year, because the way CMS has always ran their programs, they want you to have every opportunity. They don't want to talk about hardship until they've closed the door on the reporting. So we'll probably see more on hardships towards the end of the next calendar year. You're going to have still probably the same types of reasoning for applying for that hardship exception under the ACI category: disaster, bankruptcy, your EHR went out of business. There again, but remember, we've talked about non-patient facing. That exception category goes away for just overall ACI, though your ACI will be reweighted if you're non-patient facing. So hardship exception changes a little bit, probably going to be about the same process.
Yeah, and you can have a MIPS hardship. I mean, they make very clear that if you can't report under MIPS, say you have an individual provider. We're not talking like in a group situation, but an individual provider cannot attest because their EHR is totally down, or whatever the reason is, and you're applying for a separate hardship exception for the MIPS reporting, you would go into this hardship exception channel. As we said, we don't know whether it's going to be part of the normal hardship filing or whether they're going to create a separate filing. My guess is going to be rolled up with the general hardship filing. But let's just talk about that as that becomes part of the next year's reporting.
Now, payment adjustments, whether it's up or down, they apply the payment adjustment to the provider at the combination of 10 NPI. So for that specific 10 or NPI, so let's say you have a provider who is an exceptional provider. They're getting the 4% increase. They move to another organization. It's no longer the same 10 NPI, so that will not follow them. The good thing for you organizations out there that are always recruiting provider and have new providers starting, if they were getting a downward adjustment, they're not bringing it with them. They're not carrying their baggage in, so that's a good thing. Providers that are part of an alternative payment model, everybody that's in that APM gets the same score. Right,
if it's advanced. If it's not advanced, if it's, for example, a regular shared savings ACO, that's not advanced. But if it's an advanced model, everybody gets the 5% without doing anything else.
Now, over the coming years, this chart shows you where you're going to get your upswing, or you're either going to catch the carrot or catch the switch. So it's up or down 4%. For those that do exceptional, you could get up to 14%. Now, the key here is, remember, this program is difficult because it's budget neutral. People have to fail so people can get the carrot. So if it's a terrible year, you're going to see the 14% out there being available to folks. And also for those that are in an advanced APM, you get that immediate 5%. So over time, you're going to see the carrots growing. So is the switch. You get into 2024, 2025, 9%. That's real money, especially when you're being squeezed on what can be billed, billing practices, and all that jazz. 9% is real money. We've got several other webinars coming up. Like we talked about before, the next webinar is our information blocking audits. Get your compliance folks on this one. Get your legal folks on this one, because part of this one, yes, ONC is looking at the EHR vendors to make sure that the vendors being implemented, quote unquote, in the wild work as they were tested. But they're also looking to see if you've turned off some functionality that does not allow information to flow as it should. So the eyes on both sides on that one, get there for that. We're going to do a deep dive into MIPS. We're going to do 2 sessions, exactly the same information. So please just sign up for one of those, and we are going to record those as well. And then we're going to do a deep dive in the APM. And God love you if you can understand. I always jokingly say, if you can define in 2 sentences what an advanced APM is and anybody can understand it, you're a genius. So
okay, let's look at questions.
All right, so pull up my questions here. Oh my Lord, we've got a bunch, Cathy. All right, this was a comment requesting information about how locum tenens clinicians will be assessed under MIPS. The response said, locum tenens clinicians bill for the items and services they finish using the NPI of the clinician for whom they are substituting, and as such do not bill Medicare on their own. Does this mean that data generated by locum tenens clinicians should be included in the data for the provider for whom they are substituting. Yeah, they're working in place of that provider. So while they're there, they are that provider. I mean, so their numbers would be included in that. Correct, Cathy?
Yes, I would say that is correct. They are not billed under their own NPI, but under the other provider's NPI.
Where is this going to be recorded? Because the sound's not available to me. Apologize that you didn't hear the sound. This will be posted to the CliniSync YouTube channel in the next couple days, and when I do get that posted, we'll send the link out to all those that attended. Is there any way we can print the slide deck now? Sorry, we didn't get the slide deck posted before. You're going to receive it here following the webinar.
Yeah, this afternoon.
This afternoon, and you're also going to get a survey link, and we please ask that you fill out the survey because we do look at those. I'm presuming that if a provider is Medicaid eligible but bills less than 30K or under 100 patients for Medicare Part B, then you do not need to attest via MIPS.
That is correct. If they are a low volume provider under MIPS, they do not need to be included in your MIPS reporting, but you would continue to report for them under the Medicaid EHR incentive program.
The next question is, and I don't understand it. Is this true if you're in a group? I'm trying to go back up to see where that person might have first submitted a question.
If you're yes, if as far as the Medicaid, it would be true regardless of, as I said, if you're part of a group and you're a low volume provider, you can report your low volume providers as part of that group, but they just won't receive incentives.
And that also applies for locum tenens working in place of a provider. Yes, their numbers roll up right into the group as well.
Yeah, well, PowerPoint slides will be available this afternoon.
So if we submit measures via the EHR vendor, how exactly should that process work? Now, I'm going to warn you, some providers have problems with this one.
Yeah, we're going to talk a little bit more about this under the MIPS deep dive because I think it's important people understand what their options are for reporting. And there are going to be new requirements as to who you need to report on as far as patients. So I don't want to say blanket what the EHR vendor process is because some are better than others in providing quality reports for you, but we will talk about that next week. And I'm not trying to avoid it, but there's a lot of ins and outs there. But let's just say that the EHR vendors have the opportunity, should they so choose, to report your meaningful use measures and your clinical practice improvement, but they have to let CMS know if they are going to be eligible to do that.
And the way that process generally works is your vendor will perform an extract directly from your system. They massage the data however it must be done to get it into the CMS required format, and then they are responsible for submitting that information up. And that is our last question, but let me check to see if Thank you so much for attending. Get signed up for our future webinars, and we're here to help if you have any questions. Thanks
all. Have a good one.